Hi guys, we're going to talk about chapter 26, and this is going to cover crisis and disaster, and I'm just going to get started here. So when we think about crisis, I want you to consider each of these scenarios and determine, are these crises? A hurricane rips into a coastline, levees fall, 80% of a major city floods, and nearly 2,000 die. A 29-year-old man enters a crowded nightclub and begins shooting indiscriminately in the name of religion, resulting in the death of 50 people. A nursing student discovers she's pregnant and the father of the baby has abandoned her. I think they're all crises, but they all have different components of crisis. So let's talk about crisis here. A crisis is a disturbance caused by a stressful event or a threat. This disrupts an individual's homeostasis or equilibrium. Normal coping mechanisms fail, which leads to the inability to function as usual, and equilibrium is displaced with disequilibrium. Most crises are acute and self-limited and will resolve within 4 to 6 weeks. The successful outcome for a crisis really depends on the realistic perception of the event. This could range from realistic to distorted. It is really based on a person's unique perspective and coping abilities. Minor events may seem life-threatening to some people, while others carefully consider their options. Adequate situational supports. So support people are those that are available and can be depended on. And then the last successful outcome is adequate coping mechanisms. Coping skills are acquired through cultural responses, modeling behaviors, and life opportunities. Many factors can compromise those coping skills. How many stressful events is that person going through? Are there any unresolved losses? Do they have fatigue or do they have pain? So the crisis theory came about because of one of the deadliest single building fires in history. A nightclub in Boston was filled beyond capacity when a fire broke out, and the only escape route was a single revolving door at that front entrance. The door became jammed and unusable, thus leaving many individuals trapped inside. Eric Lindemann conducted a study of relatives and friends of the 492 victims and formed a foundation of crisis theory and clinical interventions. He proposed that interventions could decrease potential personality disorganization in the immediate aftermath, and that the same interventions that helped in bereavement would prove to be helpful in other stressful events. Gerald Kaplan expanded on this theory and outlined intervention strategies grounded in homeostasis and equilibrium. And then Albert Roberts created a 7-stage model of interventions, which is a useful model in helping those that have suffered from an acute crisis. So what are the types of crisis? Understanding the types of crisis lays the groundwork for the nursing process. So we can talk about maturational crisis, situational crisis, and adventitious crisis. So let's break each of these. Maturational crisis, Erik Erikson, he's a developmental theorist that we haven't talked a lot about, but we will talk about once we get into our pediatric course. He believed that maturation occurs across the lifespan in 8 stages. He believed that if crisis is resolved in one stage, this will increase the ability to pass through subsequent stages. If the crisis is unresolved, problems can adversely affect new learning. Examples of maturational crisis might include leaving the home during late adolescence, getting married, or birthing a child, or even retiring. Factors that could disrupt progression through maturational stages could include alcohol and drug addiction. Situational crises often are unanticipated loss or change in life events. These changes may arise from events that are extraordinary, external, and often unanticipated. Examples could include a loss of a job or a change in job, maybe a death in the family that was all of a sudden, a change in financial or marital status, or psychiatric or physical illness. Remember, these are unanticipated life events. And then adventitious crisis. These events can be natural and include epidemics, floods, fires, and earthquakes. These events can be human and include one-on-one violence, such as things like rape, acts of terrorism, war, riots, shootings, and bombings. And they can be also caused by accidental. So airline crashes, structural collapses, nuclear power plant failures. It is possible to experience more than one type of crisis. Consider our 51-year-old woman who may be going through menopause, that would be maturational, and then her husband dies suddenly of cancer, which would be situational. So a couple of different crises that individual would be going through. Kaplan identified behaviors that followed a fairly distinct path, and these behaviors are categorized in 4 different phases. So let's look at these. Phase 1, a person is exposed to a serious stressor or problem, which results in increased anxiety, which then stimulates the use of usual coping methods and defense mechanisms in an effort to address the problem and decrease the anxiety. Phase 2, if the usual coping or defense mechanisms fail, then the threat persists, our anxiety continues to increase, which produces feelings of extreme discomfort. Functioning becomes more disorganized, and trial and error attempts at problem solving starts to begin. Phase 3, if trial and error attempts fail, anxiety can escalate to now severe or panic levels, which leads to automatic relief behaviors are mobilized, leading to maybe withdrawal or flight behaviors. Resolution may occur at this stage or may be achieved by compromising needs in order to reach an acceptable solution. And then the last phase is phase 4. If the problem is unsolved and coping skills are ineffective, anxiety will overwhelm the person, which can lead to serious personality disorganization, depression, confusion, maybe violence against others, and even suicidal behavior. So let's start the application of our nursing process. We understand the different types of crises and we understand the phases of crisis. So let's start our process. So we know we start our nursing process with assessment. So when we think about general assessment, is there a presence of suicidal or homicidal ideation? Remembering we want to keep our patients safe. Self-harm is a distinct possibility. This should also guide the nurse and the patient in setting realistic and meaningful goals. So I'm going to introduce you to Madison. Is a 24-year-old woman who is brought to the emergency department by police after being beaten by her husband. Madison is seen by the medical personnel and then interviewed by the psychiatric mental health nurse working in the emergency department. The nurse calmly introduces herself and tells Madison she would like to spend some time with her. The nurse says, "It looks as if things are pretty overwhelming. Is that how you are feeling?" Madison sits slumped in a chair, her hands in her lap, head hanging down, and tears in her eyes, and she nods. The nurse makes this observation that things must be very bad if Madison stays with her abusive husband. So after we've assessed for safety and general assessment, then we're going to assess perception of the precipitating events. The clearer the patient can define the problem, the more likely to identify an effective solution. So the nurse says, Madison, tell me what happened. Madison, I can't go home. No one cares. No one believes me. I can't go through it again. Tell me what you can't go through again. Madison starts to cry, shaking with sobs. The nurse sits quietly for a while and then speaks. Tell me what is so terrible. Let's look at it together. After a while, Madison tells the nurse that her husband has been beating her regularly, although particularly after a night of drinking. The beatings have become much more worse over time, and Madison states, I'm afraid that eventually I'll end up dead. So we've assessed the perception and the precipitating events. So now we need to assess the situational supports. Assess and determine the support system of the patient. If there is no support, the nurse may actually need to act as temporary support until that patient is able to establish relationships with family, friends, support groups in the community. Madison, what are your options? Do you have any family who can support you? No, my family is in another state. We stay pretty much alone. How about friends? I don't really have any friends. My husband's jealousy makes it difficult for me to have friends. He finds fault with everyone. What about people at your place of worship or coworkers? My coworkers are nice, but I can't tell them things like this. They wouldn't believe me anyway. The nurse learns that Madison does well at her job. Madison explains that her job helps her forget her problems for a little while. Getting good job reviews also has another reward. It's the only time her husband says anything nice about her. So now we've gotten her perception of the precipitating event. We've assessed her situational supports. So now let's assess personal coping skills. Positive coping mechanisms could include seeking out someone to talk to, maybe writing in a journal, engaging in exercise. Ineffective coping would be things like overeating, drinking, smoking, yelling. So the nurse says, you've been through an emotionally painful time. Your anxiety is understandable. What has helped you in the past to make you feel more calm? I don't know. Probably talking. Okay, while you're here, we will talk for at least 30 minutes each day. In group therapy, you will have the chance to share what you have been going through and also hear about how others cope. Thanks. I don't want to be in an abusive marriage. I just don't know where to turn. I understand. We will work together to come up with a plan. Nurses need to acknowledge personal feelings and thought. Even experienced nurses can become overwhelmed. Debriefing is an important step to come to terms with overwhelming violence. This helps staff put the crisis in perspective and begin that recovery process. So let's talk about nursing analysis and outcomes. As far as nursing analysis, that it can include for risk for impaired coping. It could be a risk for impaired coping. It could also be that they are impaired coping. Risk for or actual impaired family coping, risk for or actual impaired community coping, and anxiety. Overall outcomes for coping are aimed at effective coping for that individual, the family, and community. The overall outcome for anxiety is to reduce that anxiety. These overall outcomes will be patient-specific to that patient's needs. So as we think about planning, this will happen through a variety of crisis intervention modalities, which may include mobile crisis units, group work, health education, and maybe even crisis prevention. Implementation will focus on patient safety, anxiety reduction, by developing that therapeutic relationship, remaining with the client, listening, observing, and making eye contact. We're going to demonstrate genuineness and caring and avoid any false reassurances. We also want to make sure we use an appropriate level of prevention and debriefing. So as we look at levels of prevention, this can include primary, secondary, and tertiary. Primary prevention promotes mental health and reduces mental illness to decrease the incidence of crisis. So on this level, the nurse can recognize potential problems, teach the patient specific coping skills, and assist the patient in evaluating the timing of life change. So if we're thinking back to Madison and we're on that primary level of care, after talking with the nurse and the social worker, Madison seems open to going to a safe house for battered women. She also agrees to talk to a counselor at a mental health facility. The nurse sets up an appointment at which Madison, and the counselor will meet. Secondary prevention is interventions during an acute crisis to prevent any prolonged anxiety. The nurse's primary focus is to ensure safety and assess patients' problems, support systems, and those coping skills. So if we're thinking about the secondary level of crisis with Madison, the nurse performs secondary crisis intervention and meets with Madison twice weekly for 4 weeks. Madison is motivated to work with the social worker and the nurse to find another place to live. The nurse suggests several times that Madison starts to see a counselor in the outpatient clinic after the crisis is over so that she can talk about some of her pain. Madison is ambivalent and is already thinking she will return to her husband. Tertiary prevention provides long-term support for those who have experienced a critical incident stress debriefing, or CISD, is an example of a tertiary intervention that's directed toward a group that has experienced a crisis. And it goes in 7 phases, and the 7 phases include introductory phase. This is where the meeting purpose is explained. It'll move to the fact phase, where the incident facts are discussed, the thought phase, where we discuss the thoughts, reaction phase, we discuss the worst part of the event, symptom phase, cognitive, physical, emotional, and behavioral experiences are described, teaching phase, which is where we acknowledge and affirm, and stress management techniques are used, and then re-entry. This is where we bring closure to our debriefing. And then the last component of our nursing process is evaluation. The goals of crisis intervention is to return people to their pre-crisis level of functioning. So Madison returned to her husband 3 weeks after the battering episode. She has convinced herself that he has changed his behavior, despite the fact that he has not sought any help to control his anger. After 6 weeks, Madison and the nurse decide that the crisis is over. Madison is aloof and distant. The nurse evaluates Madison as being in a moderate amount of emotional pain, but Madison feels she is doing well. The nurse's assessment indicates that Madison has other serious issues, low self-esteem, maybe childhood abuse, and the nurse strongly suggests that she could benefit from further counseling. The decision, however, is up to Madison, who says she is satisfied with the way things are, and again states that if she has any future problems, she will return to the safe house counselor. So when we think about crises and the treatment modalities, emergency rooms, ERs are not ideal. ERs are expensive, and they may lack time and staff with specialized training that's necessary for our patients' needs. Behavioral crisis care services can include crisis call lines. Those are those 1-800 numbers that can assist with online chats. Our warm lines are similar to crisis lines but provide confidential phone support. They're usually more emotional support and comfort, and information can be provided. Crisis intervention teams are a team of people that can be available in the home, the workplace, or other community-based locations. And the last one there is crisis stabilization facility, and that just provides short-term care and quick de-escalation crisis. When we think about psychiatric advanced directive plan, usually advanced directives are used in end-of-life situations, but in psychiatry, these plans take the form of a document that is developed by the consumer to be used in crisis situations where the consumer is unable to make decisions. Modalities of crisis intervention. Again, nurses are going to intervene in these different modalities. You could be in the ER, you could be on a telephone hotline, maybe a peer crisis service, on a crisis intervention team, crisis stabilization bed, or even in a short-term residential service. So that finishes our crisis part of this chapter, and we're going to move into disaster response and just talk briefly about disasters. So there is a growing awareness among all members of the global community. Each successive large-scale earthquake, tsunami, hurricane, flood, or wildfire has ripple effects regardless of where in the world it occurs. The coronavirus pandemic that started, you guys are well aware of, in 2019, significantly increased our understanding of the magnitude of disaster. Being prepared for such disasters helps develop resilient communities, assess disaster risks on a local level, extend to networking communities, and extend to larger societal and national programs. When we think about the disaster response, FEMA's 4-phase disaster management continuum is outlined as such. Mitigation, which is an attempt to limit a disaster's impact on human health and community function. Preparedness is the protective plan designed before the event takes place to structure the response, assess the risk, and evaluate the damage. And then the response is that 3rd phase, and this occurs in the immediate aftermath. And then the last is recovery. That's when restoration efforts occur concurrently with regular operations and activities. As far as disaster management context, we can think about Department of Homeland Security or the National Incident Management System. I'll let you just read through those. I'm not going to get too involved in each of those. And that concludes chapter 26 over crisis and disasters. If you have any questions, you can shoot me an email or we will chat about it in class. Thanks, guys.